Courtney, for having me. It's very good to be back at the Rockefeller Foundation speaking on difficult public policy matters. I've always got a lot out of Rockefeller Foundation events, and I'm getting a lot out of this one already. This is as important an issue facing the city of New York as any other we face. I saw the mayor the other day with Deputy Mayor Gibbs, and we talked about the challenges for HRA going forward into the next year, and helping and participating and supporting the proper implementation of healthcare reform in New York State is our highest priority. It's as high as we get. We've achieved a lot in New York City and in New York State, and we don't want to lose that. We want to continue to go forward. And it did remind me a little bit about my background, that I had, one of the first things Deputy Mayor Gibbs did was she called us all together, all the various city agency leaders, policy analysts in the big room, and we had a briefing similar to what Dr. Knickman just did for us from the Washington people. What was in the bill? You may have heard about it, you may have thought about it, you may know some parts of it, but let's do the full briefing. And as I sat there, I was reminded of a similar briefing that I had, that I participated in here in Albany back in 1996 or 97, right after another major federal change took place, federal welfare reform. And I have to say that the complexity here, this year, the detail, the difficultness of the assignment seems to me to be much greater. Welfare reform had a lot in it, a lot of new things. There were some ideological aspects about it, but it was manageable. And it turned out, I think, ultimately to be manageable. This seems much, much more dramatic and more difficult and more challenging. And so the Deputy Mayor and the Mayor have asked that we gather everyone together and begin to work on proposing and thinking about what we think would be best in concert with the state. And one of the fundamental questions I'm going to get to the slides in a minute, is a structural issue, and it really goes to the local-state relationship. Is that in Medicaid, which we run in New York City with regard to eligibility determination, it's a shared responsibility between us and the State Department of Health. I think going forward, we're really going to have to think about that very carefully. Are we going to continue this shared responsibility? And whenever you have a shared responsibility, sometimes you have no responsibility. Or are we going to really centralize the authority and the control and the decision-making in one entity? And I think that's a very difficult topic to take on, but needs to be addressed. And I also would say, as I sit here listening to the Assemblyman, that it's also an issue the state has to decide within the state. So it's a local state issue, and then it's a state agency governor's office issue. Someone who worked in Albany and had this sort of relationship, DOB, Governor's Council's office, state operations, and agency, leaving aside the legislature on top of that, to the extent that the state can resolve how those decision makings are going to get made in some coherent, centralized way, I think will be very important for the new governor. So, to my slides. What happened to my... There it is. Okay. So...
Upside down.
Upside down. Okay, there you go. Just to reiterate some of the things that were talked about previously, but I do want to emphasize we start from a good spot in New York State compared to the rest of the country. We have dramatically expanded eligibility for public health insurance. We have some of the broadest, most generous eligibility standards in the nation for public health insurance. And we've done insurance reform with regard to pre-existing health conditions. We have the strongest private health insurance rules in the country, including requirements for insurers. They cannot deny coverage or charge more individuals based on their health. So we start in a little bit ahead of the rest of the country. In fact, as I watched the reform taking place, I often thought that the debate in Washington was about how we get the rest of the country to catch up with us. In New York City, we have maximized the impact of increased accessibility of public health insurance through enhanced customer service, technological innovations, and aggressive outreach to facilitate enrollment. Here, the State Department of Health help and ours, using computer technology, we really have gone after everyone we could who was eligible to get them covered. And our goal has been very explicitly, from Mayor Giuliani through Mayor Bloomberg, let's ensure everyone eligible for public health insurance is enrolled. And there have been a significant decline in the number of uninsured in New York City in the last 10 years. Enrollment in public health insurance has grown by 65% since 2002. Our uninsured rate has fallen from 24% to 19% for non-elderly residents, while public coverage increased from 25 to 32%. And one that I'm particularly proud of, we have the lowest uninsured rate for children at 5.8%, among the nation's 10 largest cities. An uninsured rate of 5.8% is virtually universal coverage for children. So we've achieved a lot in New York City, and we want to maintain those achievements. How have we done it? We've talked about using technology to make the access easier. We have model offices for the Medicaid program, mail-in renewal. We have an elaborate 311 system that the mayor is very proud of, and we have online informational resources. We have something called edits, which allows us to receive applications from facilitated enrollers electronically, and we hope in the future, hopefully near future, to begin to receive renewals for public health insurance also online. That would be a significant advancement, which we're looking forward to. So we've done a lot there. We also, through leadership from the mayor's office, had a strong health stat initiative, which made it very clear that that we had to get everybody mobilized in increasing enrollment, every city agency, managed care plans, broad range of community and faith-based organization. This was one of those numbers that the mayor's office was going to focus on and see how we did going forward. So that has been successful. It was particularly successful after 2001, 9/11. Then we also recently announced New York City Health Insurance Link, which allows a web-based tool for individuals and small businesses to look at and and search for health insurance products that are best fit them. And that's been remarkably, we think it's great. The hits have not come on as fast as we hoped, but they're coming on more every day. So we look at the goals of health insurance reform from the federal government: more coverage, more oversight, and better health. I'm going to focus mostly on more coverage, more oversight. Better health is a little bit outside of my bailiwick, but we may get to that in the questions and answers. We definitely want to participate in the decision-making process as we determine these rules. There's so much complexity involved here. In New York City particularly, but also local administrators generally, have a lot of experience in actually dealing with clients and processing applications. And I think it's important that we have a process that involves us all. And I think that to the extent the New York State Health Foundation can help in that would be great. The next is sort of more of the same. We want to share that. We want to help residents, business employers understand the new rules, regulations, and taxes. Here is the big question when it comes to, for us. The federal bill calls for seamless interface between the public health insurance products and the exchanges. So how are we going to do that? Our experience has been more with low-income population, 133% of poverty or lower. We've done very well with that. But now we have a whole new group of customers who need to be serviced in a different way. How are we going to achieve the seamlessness of that if we don't, or if some single entity does not own it? It's one thing to achieve seamlessness if it's all in one organization's hand. If it is in multiple hands and there's a handoff involved, it's not so simple. So I think that's as big a question that needs to be decided and discussed in the coming months as there is. And that is the seamlessness issue, as well as whether New York City could have its own exchange. And I should say, the city is considering and wants to really think carefully about our desire to ensure that what we have in New York City protects our residents. And so to the extent that the city determines that we can take care of our part of the pie as well or better than the state can, we may want to be involved in that discussion. So if there's a possibility to be seamless but not necessarily connected to the state, that's another opportunity to consider. And so again, and then as I said, we think we've had success expanding coverage for low-income population. How do we translate that success to businesses, to people who are not so low-income? We've talked about the primary care supply. Clearly what happened in Massachusetts and what seems to happen when you expand coverage is of great concern to us in terms of the availability of physicians. We were disappointed in the city of New York that the undocumented immigrants issue was not tackled. In fact, an explicit commitment was made not to tackle it in healthcare reform. The vast majority of the people that are uncovered for health insurance at HHC, Health and Hospitals Corporation, are undocumented immigrants. This is our biggest hole, and it will remain our biggest hole. And there are concerning potential reductions in federal funding for the disproportionate share hospitals, again, HHC. Major concern to HHC going forward. And there's sort of some hope, I think, as somebody Morelle indicated, that, well, that will get taken care of later. You know, we won't really let that happen. But that's a great concern to us. And then, of course, I was interested in Dr. Knickman's comments about the mandate, to the extent that the mandate works to make people step up to a responsibility. That would be great. If there is not a lot of take up of the mandate, we have an issue. So the federal government made a choice. They wanted a mandate. There is a mandate. In federal welfare reform or welfare policy, we're very comfortable with saying to people, you have a personal responsibility to do your part too. We hope that that works as well here as it did there. Now we come to financing concerns. This is a large one for the city of New York, not gotten much discussion, but it's worth considering. When you look at the financing for healthcare reform, there's $456 billion in cuts to Medicare providers. To what extent are those Medicare providers New York State and New York City Medicare providers? And to what extent are those providers going to have to support the legislation with these cuts, and how will they absorb these cuts? And then almost as large, there's a very large $438 billion in new taxes. This is federal taxes and fees for citizens and residents. To the city of New York, it's something like $6 billion. $6 billion in gross tax revenues moving from the city of New York to the federal government. If you combine that with the expiration of Bush tax cuts, which will also have an effect on taxpayers in New York City, we have a very significant shifting of dollars from city of New York to Washington. Now, Daniel Patrick Moynihan and others have tracked that very closely, and we like to get our fair share back. But the extent to which that affects our economy is something of some concern to us, and the mayor expressed that at various times during the debate. The other question I wanted to mention, I wouldn't ask, was that I've mentioned all those questions. The other is the cost. I completely agree with Assemblyman Morelle, the cost control aspects of the bill. And in HRA, we also have responsibility, in addition to determining eligibility, for doing what we can on waste, fraud, and abuse broadly, both in concert with the Office of Medicaid Inspector General and on our own. But it's a hard fight, and we were gratified to see that President Obama and the White House put out a number of stuff about greater efforts in inappropriate payments and greater cost controls. I think what really we'll have to see what comes of that, because if we don't get a control on the costs, I don't know that we'll have as much success as we could otherwise. So that's another big concern. There's also workforce opportunities. I, as an agency that runs the welfare programs and deals with a lot of people seeking jobs and opportunities to move up the advancement, move up the economic ladder, obviously community health workers, caseworkers, nurses, home health aides. There's an opportunity there for us to improve the quality of life for employees and clients of public assistance by finding opportunities to work in the healthcare industry. We want to make sure that we maximize that in New York State. And then prevention and wellness opportunities. And again, it's a little bit outside of my bailiwick, because I'm not the Commissioner of Health, but there's great opportunities there. And I assure you that Commissioner Farley and the City Department of Health will be very aggressive on all of this as well. And we're looking forward to that. So that's my presentation. It echoes a lot of the themes of the previous speakers. I would just emphasize that this is a very, very opportune time to gather up, to consider, and to have, I think, for the new governor and his team, a good start in determining how the state responds to these opportunities. So I look forward to questions.